There we go.
Hello, everybody. Through the miracle of modern technology, we are finally here today with Professor Vivian Strong, who's I like to think of as an old friend. It's great to see.
Thank you. It's great to be here.
Yes, this is the Artificial Intelligence and Cybersurgery Podcast. It's from the journal where I'm the editor-in-chief. My name is Dr. Andrew Gumbs. We're the first journal dedicated exclusively to artificial intelligence and surgery. And we're so happy that we were able to get Zoom to function that I think we're all of us a little bit flabbergasted, but I'll let my co-host, Dr. Vincent Grasso, reintroduce our guest today. Go ahead, Vincent.
And thank you, Andrew. Dr. Strong, it's a sincere pleasure to have you on our podcast. As Andrew said, it's dedicated to all things AI and surgery. I don't want to steal your thunder of the very interesting things that you're going to be talking about. I do encourage the audience to go to mskcc.org, the Memorial Sloan Kettering website, and type in Vivian Strong into the search and look at her very excellent profile. You'll be impressed, as we all are. So thank you for being on the show. And please tell us what the Iris Cantor Chair is. I mean, that's your title, which is a very prestigious title to have. If you could just tell us a little bit about your background, and then we'll jump into the details.
Sure. Well, thank you very much. And again, I do also think of you as an old friend, Andrew, and Vincent as a new friend. So it really is a pleasure to be here this morning. In terms of background, I am a surgical oncologist. I did a minimally invasive training fellowship way back in the day. That was the time when laparoscopy was the big new thing on the horizon. So that will be interesting to talk about how this has merged into robotics. I have now been on staff at Memorial Sloan Kettering for the past 17 years. Don't do the math, please. I know, don't do the math. And I have focused on minimally invasive approaches to gastric cancer and adrenal tumors. So gastric cancer as a discipline is my main interest, both from a surgical and a research perspective. But the minimally invasive fellowship I had was just a perfect way to apply this cutting edge at the time technology towards better operations for our patients with minimally invasive surgery. I did the same for adrenal tumors as well. Then fast forward to about 2010 or so, I was able to the robot became more and more interesting. We had a plethora of robots at Memorial Sloan Kettering. We were very fortunate to have a urologist who was the chairman of surgery and was very forward thinking about getting robots, having people interested in that technology. And that allowed me to have a platform to transition from laparoscopic to robotic approaches for gastric cancer. And I initially honestly thought that I would not like it. I thought, I know how to do this laparoscopically. I'm sure Andrew's nodding. He probably had similar experiences.
Right.
And he said, I'm going to commit. I'll do 50 robotic gastrectomies and reassess. And then I thought I was going to go back to laparoscopy. Never turned back.
Wow, that's interesting. I actually didn't know that. So what percentage now are you robotic?
So I would say about half of my cases I'm doing robotically. In the cancer world, there's some unique aspects. You always need to make sure that you do a safe and oncologically sound operation. So there are always going to be some cases in cancer, as you know, Andrew, that are just not amenable to a minimally invasive approach. Big, bulky tumors, organ invasion. It is a little bit of a moving target in terms of your expertise and what you're willing to challenge yourself with as you've grown your expertise. But there will always be the cases that need to be done with an open approach.
No, of course, but what percentage? So what percentage are laparoscopic is what I'm curious about. Is it robotic or open, and that's it? Interesting.
I've only gone to robotic or open. The only cases where I might occasionally do a laparoscopic gastrectomy would be maybe a GI stromal tumor, one where
like a sleeve or something that you just need to do a little sleeve or something.
Exactly.
So Vincent, I can't remember if I told you, but I met Vivian because you. Now remind me, correct me if I'm wrong, but were you also a resident at Columbia?
I was a surgical I did my training, both medical school and residency at Cornell.
Cornell,
then
okay.
Training was the minimally invasive training with a famous set of superstars that were both at Cornell and Columbia. It was a combined fellowship only for, I think, 1 year or 2 years, because there were a lot of superstars, and I think there was a lot of, but
no, I think it was two. The reason I say that is because the way I met you was your last day of fellowship was my first day of fellowship, because I followed you, and I started at Cornell with Michel Gagne, Alphonse Pomp, Gregory Dakin, and then I did my following 6 months with Mark Bessler and Dennis Fowler, of course.
Exactly.
So that's where we first met. I remember interviewing it, and I saw this. We basically, in Italian, we would say the equivalent of this stallion, if I can say this Vivian Strong, and I'm like, I'm definitely want to go. I would definitely want to do my training at the place where someone like that goes. And
well, you have a wonderful memory, Andrew. So
we're very visual creatures, us surgeons. So then you transitioned, or you really focused on gastric cancer, which was obviously a very smart choice for you. And how was it? Because you were really one of the pioneers in the minimally invasive world in surgical oncology, and you were really in the mecca, or in the mouth of the beast, if you will, of people who are not huge fans of minimally invasive surgery. So how were those dark periods, and how have things changed?
Yeah, it's remarkable, and I'm sure you have many stories that are similar. But I think transitioning to Memorial, it was more really by happenstance than by devise. I didn't particularly think when I was doing my fellowship that that's how things would end up. And it's interesting how careers kind of progress in ways that you can't always predict. But when I went to Memorial, there was certainly a need for minimally invasive surgery. I remember actually my first night on call as an attending, I was called about an appendicitis. And just to give you a sense of what those days were like. And I said, okay, book it. We'll do a laparoscopic appendectomy. Those days you went right away. Right. And I got a call back from the head of anesthesia who said, if you're booking this laparoscopically, then it's not an emergency. And so that was kind of where we started from at that point. And I think there was a lot of vision at the point. Yuman Fong was there, Murray Brennan. I think they all recognized the importance of moving ahead and taking the cancer world and combining it with appropriately selected minimally invasive approaches. So, fast forward from that kind of environment and that mentality, we slowly started changing things. Applying all of those minimally invasive approaches to gastric cancer was there was a need for someone to do gastric cancer. I had the skills from the bariatric training, the incredible bariatric training I had at Cornell from Gagne and Bessler and that whole crew, and Dr. Fowler, his tremendous mentorship. So I think that all really just brought together this perfect storm where I could apply this technology in a newer kind of way, very carefully and very safely, and start moving things ahead. In the same time, the colorectal group also was getting more and more interested in laparoscopic colon surgery. This was back in the day. And so I think that momentum together, it was sort of the GI tract. We said, no, there are real indications here. There are real benefits for the patient. And it's not compromising cancer care. So I think that's what really launched this. And then more and more people, we reached this critical mass at some point, and then it's just exploded.
And you get those comments in conferences now, like, like I've always said, the minimally invasive way is the way to go. The people who would yell at you the most are now like, I always knew it was the way to go.
Right, exactly. Well, it's so funny because I used to be asked, why are you doing this case minimally invasively? Yeah. Now, when I'm in the OR, fellows will say, why aren't we doing this minimally invasively? I have to defend why I'm not doing the case. It's crazy. It's a fun transition to have been through.
And when did you start using indocyanine? Or do you use indocyanine, I should ask?
I do, yeah. I mean, I think the robotic platform is so incredible. I'm sure we'll talk about that. But, it's the opportunity for this image integration and is just beautiful. So when I would say maybe 4 or 5 years ago, I started experimenting with Firefly technology and the indocyanine green. And initially I thought, well, let me just see what it looks like, see how it can benefit lymph node detection, particularly because in gastric cancer, it's all about the lymph nodes, and prognosis is so predicated by lymph nodes. And it's beautiful. I mean, in terms of a teaching tool, in terms of ability to identify nodes in very obese patients where you can't see nodes, but they kind of shine through the adipose tissue, it's been really a great opportunity to to improve both learning and identification of nodes. So I use it almost all the time.
And not for ischemia to check for anastomosis, just mainly for the lymph nodes.
Some of our thoracic surgeons do. So I have one of my colleagues, Dr. Daniela Molina. She's just a phenomenal thoracic surgeon. She uses indocyanine green specifically to look at anastomosis and make sure that perfusion is good. I haven't used it for that yet, but I think it's a great opportunity. I just haven't experimented with it.
So Vincent, I ask you, is indocyanine dye, would you consider it under the umbrella of the definition of augmented reality? And could you explain your answer to the audience?
Well, you always ask me those fun questions.
Of course.
I think this falls within the realm of hyperspectral imaging, right? So we see things in a visual, in a spectrum, right, of visible light. We don't see infrared, we don't see ultraviolet, we don't see those things. But
it's a fluorescent dye, so it's a
right.
fluorescent.
So there's So this is a technology that allows us to visualize something through the injection of a material that allows it chemically to glow, so to speak. And without that, as Dr. Strong has mentioned, and adipose tissue and whatnot, you wouldn't see those lymph nodes, right? You just don't visualize them. So we're moving down a very interesting pathway of bringing new spectral augmentation to be able to visualize things that were traditionally hidden. And as you mentioned, seeing that there's good vascularization around anastomosis, you can't see that in the visible spectrum without the augmented reality that you brought up. So this is super exciting, right? For especially telesurgery, when you don't have the benefit of being physically there, that you can go and palpate stuff. And that's why this is so, and Memorial and Dr. Strong, they're so cutting edge. This is great for patients, and it trickles down eventually to, the masses, right?
I agree completely. But the more I think about it, though, I really do think of it as it falls within the umbrella of the concept of augmenting our reality, right? But the jury's still out of whether it's, the way the term is used, the way the term AR is used. So, but anyway, I think for our purposes, I think it's helpful to consider it augmented reality.
Absolutely.
I think it's so interesting that, people are a bit afraid of the robot. You see it even with our patients, they're like, are you doing the operation or is the robot doing the operation? You're like, no, we're doing it. This is like an avatar. But I think there is a lot of, speculation. There are pros and cons to using these robotic platforms. And the bottom line is it's not going away. It's here to stay. And I think personally that just jumping in, embracing the technology and exploring what is good about it and what is bad about it is key for us as surgeons, because it's the advantages are tremendous. I don't know if you want to talk about some of those, but I think for anyone who does robotic surgery, you don't look back because the advantages are significant for the surgeon, for the patient, for the image integration.
I think that the best thing about robotics is actually once you hit the, I don't even want to say my age. I'm at the age where I don't want to say my age, but let's just say when you reach a certain age, your eyes aren't what they used to be, and also your stamina and your energy. And I really think that the main power of the robot actually is once you're with age, it's a beautiful thing. Once you have more experience, once you're more comfortable, I actually think the robot in many ways is for people with more experience. I think people erroneously thought that it would make people who aren't laparoscopic surgeons into minimally invasive surgeons and what have you. But I actually think you need a higher level of training. I think you need that open experience. I think you need that laparoscopic experience. And then you're ready to unlock the full potential of the robot. And just like you say, Go ahead.
No, you go ahead.
You're great. So, because for me, what's interesting, the most interesting thing about robotics is not telemanipulation. I talk about the 6 levels of autonomy, of surgical autonomy. We talked about this in a white paper. I believe you're an author, but a co-author. But level 0 is no autonomy. Level 1 is telemanipulation, actually, which is the lowest form of autonomy. So to get to levels 2, 3, 4, and 5, 5 being full autonomy, where the robot actually, is like what everyone thinks, where they're doing the entire operation. But to get there, we have all these steps to have parts of the procedure being done autonomously, like the stapler. When you use the stapler now, does it have a sensor, the one for the Da Vinci, the one that you use, where if the tissue's too thick, it won't fire or it'll slow down. So it has a level of autonomy. So I actually think the stapler, for example, is level 2 autonomy. And then I like to use the ligature. Do you have the ligature for the robot you use? And it has 3 different options, right? 3 different buttons.
Yes.
So that's level 3 autonomy, because you have different options to choose from, and it's the robot, the machine, that chooses once the vessel is ready to be cut. Once it's not you that decides, it's the machine. And that's exactly why I completely agree with you. You have to be fluent with the robot, because for us to get to more and more autonomy, for us to be able to do more and more complex operations, we have to get in at the ground floor to understand these concepts, because people don't understand robotics and autonomy and artificial intelligence. And that's exactly why we have the journal, is so that surgeons can become more facile with all the different nuances of the potential of robotic surgery. And we could talk for hours on what is robotic surgery. Just like you said, people are thinking that the robot does the surgery. That's where the word robot comes from. I think it's Czech. It means slave. Where the slave does it. But I tell my patients, like, that I'm not the robot / I'm not the robot's not doing it. I'm the slave, is what I'm thinking in my head. Because, like, as you're still doing the entire operation.
Yeah. Well, and I really think that you're so right about what this does for the surgeon. And I think for more experienced surgeons and beginner surgeons, it's very valuable, because you are more comfortable. I think as a result, your stamina increases. We've all been in these cases, 4-hour, 5-hour cases, where laparoscopically you're holding the instruments, your back is sore. There are a lot of surgeons at our age and above that start having spine issues, even spinal surgery, because of tremendous postural issues.
Absolutely.
So when you think about that, and even I've seen people who have tremors, the robot corrects for that. You can even for dexterity. So between the visualization, the ability to increase our stamina, and the ability to have these corrections and multiple arms, there are so many advantages. I think it actually augments what we're able to do. And the example of that is, I was doing some laparoscopic adrenals. I lagged behind with doing adrenals robotically. And I had a very, very tough case. That was the first one. And it was a very obese patient, small little tumor on the left side. And I said, well, I'm going to try this robotically. I knew there was going to be a lot of trouble with the fatty tissue and so forth.
Right.
With the robot, I am entirely certain that I would not have been able to do that case laparoscopically. It would have been so tedious, so difficult that, your stamina, and you would have said, I can't do this. And robotically, I was able to do it. And it was the first time it dawned on me that this technology, because it's so, it integrates so nicely, but it actually extends the ability of what we can do. You can hold a position, between a right adrenal, between the liver, a big fatty liver, and this little teeny space. You can hold positions longer, you can persist longer, and you end up with better operations for the patients. So those kind of things are very exciting. I'm also kind of interested in the remote surgery, because I think the remote platform is interesting. I know you have some knowledge about that, but I think that remote surgical options for the robot really give us opportunities also to bring some of this technology, which is expensive and not necessarily available in every center, to sort of rural or underserved areas. And I think that's also an interesting topic. What do you think about that?
Yeah, this is where I love to punt to Vincent. Vincent?
Yeah, this is very exciting. I just came back from the University of New Mexico, working. I'll probably be working with the computer scientists and the computer engineers there. They have some very innovative technology for video compression. So as we move, and I'm writing a paper with Andrew about all things video that are happening in the OR. As you move from 4K to 8K, right? So you have a 4K television at home, you'll probably get an 8K television. The amount of data that has to move down that pipe is profound. And to travel over a distance so we don't have more than 100 milliseconds of delay is considerably challenging technically. So we're excited to be able to extend our ability, your ability, especially as the provider, to help the rural communities. But you need the pipeline, you need the connectivity to be able to do that so that you don't have a big lag, because you can't do teleconsultation if there's too much of a lag. You can't control the robot. So this is a very exciting topic for us. We're hoping to be able to work with you on letting you know about what the progress we're making in this space. But telesurgery has been evolving since 25 years ago at Yale, right, Andrew, and at CSC META.
Yeah, tell us about that.
Sorry?
You should tell us about that.
Yeah, we will. Oh, actually, do we? Are we still okay with time? I feel we are actually still okay with time.
Yeah.
So,
Dr. Strong, just to for our audience, people are going to listen to this and be very excited. They have patients that have family and friends that are sick. Is your department, obviously you have bandwidth. You're taking new patients, or can people contact the office and you have fellows, you have a whole team of people, obviously, right, that can handle the demand for the services, right? Okay, great.
Yes, absolutely.
We get asked that from people that are on the show, and we want to make sure we can forward people over that are interested in care. Okay, thank you. I didn't mean to interrupt you, Andrew.
Yeah, no, it's we actually, Vivian, Vincent and I have a lot of projects in this space that we obviously we can't talk about during this podcast, but as you know, we keep hounding you, and we're going to obviously contact you when the time is right, and hopefully not too long, but we'll keep that for another time. But Vincent, the way I know Vincent, I'm not sure if I ever told you, in a similar way that I met you, I think on your last few days of being a minimally invasive fellow at Yale is when I started my residency. So I think I basically, it was like two ships passing in the night. As I came, he left, but he worked with Richard Satava, which is really someone who, I'll actually let you tell that story, Vincent, about what Maresco thinks about Rich Satava.
Yeah, Maresco was at a lecture and was just blown away from what Rick had to say about the future, and it was the impetus behind him moving forward with his organization foundation. And lots of people credit Rick for being very instrumental in their careers. Michelle was a consultant at our laparoscopic fellowship program at Yale in those days, right? It was early. With Butch Rosser had his Top Gun surgical suturing courses and this stuff, and we really benefited from a lot of those early, very insightful things that Rick led at the Commercial Space Center that was at Yale. So it was
and Rick was a colonel, right?
Yeah, Rick was an Army colonel. He was the Defense Science Office project manager for DARPA. So they brought a big grant from NASA to Yale to build a commercial space center. So we were doing technology, medical informatics, minimally invasive surgery, all in the same department. It was very innovative and fun. So
Vincent, I don't know if you mentioned this to Vivian, but again, just maybe for our audience members, you just tell about your experience with Everest and the date you were doing that level of telemedicine. Remind me of the date. Was it in the 90s?
Yeah, late 90s, like 97, 98, 99. We were doing very, very sophisticated telehealth over the Inmarsat satellites. So that was only 128K. So we're all used to broadband, but we were doing live, we were doing 2D echoes live transmitted through an Inmarsat satellite to Yale New Haven Hospital radiologists live. But in the ER, they had to drop it to tape and walk it upstairs to pump it into the machine. So, too early, couldn't commercialize things. doctors didn't even have internet access, many of them. So they
Right.
were all, kind of illuminating projects, but this is the evolution of all that early effort.
Well, it's so exciting when you think about it also, because you think about this remote surgery, and the United States is such a big country, and you have other countries like for gastric cancer in South Korea, they have 12 or 14, you'd have to fact check me on the number of hospitals that all get the gastric cancer cases because it's a small country. We
Sure.
couldn't possibly regionalize our care in that way in the United States. It's just too big of a country. And when
Yeah.
you think about the way that we could potentially bring expert level surgical procedures, maybe not the whole procedure, but parts of it where an expert is really needed
Absolutely.
to these rural areas, these underserved areas, it's just amazing. I mean, there are some issues with it, of course. What are the legal implications? How do you have the regulatory implications? I know it's complicated, but when you think sort of ahead, vision towards the future, those are the kind of things I see. You even imagine, let's say, somebody in our armed forces is, serving abroad and they have a heart injury and they need a specialized cardiac surgeon, for a very specialized part. There's a potential that we can really expand the knowledge and the special expertise that we have developed as we moved along in our surgical career to really benefit more people. I mean, that part is
Absolutely.
exciting. And I think, I don't know how long it will take. It's probably another decade or two away until it's really there. But maybe less, who knows?
Andrew, can
that's
I say the magic number?
Go ahead.
Sorry? So the Lancet, we talk about this about 6 years ago, published 5 billion people don't have access to reliable surgical and anesthetic care. Wow. That's a big number. I mean, I was astounded when we looked at that article, and it's mind-boggling. But think about the value that you could bring with your fellows doing telehealth consultations remotely, to help those people go from absolutely zero surgical anything to at least an opinion about, what they should be doing, right? That's so badly needed. So, Andrew, this is exciting.
No, but just with Vivian, it's just like I'm not sure if you're aware. I think you are, that that's exactly the reason you were describing earlier, is why they invented Da Vinci. I mean, it was initially invented by the military to do open surgery for fallen soldiers, so that the surgeon could be safe behind enemy lines. So that's. But then, as you mentioned, minimally invasive surgery came along, and they completely shifted the focus of the device to minimally invasive surgery. So it's people have been thinking about these things for a long time, and I think, unfortunately for Vincent, you were too far ahead of your time back in the day. But looks like the world has caught up with things, and so now is a good time to bring some real change and some advances in the field of artificial intelligence surgery. Oh, he uses the catchphrase in the podcast.
So
Which
good.
one?
Artificial intelligence.
Yes, I had to plug our journal last time.
That's very exciting also. I mean, when you think now we have the robotic platform, but now with the advent and the, like a skyrocketing increase in ability to use artificial intelligence, like Chat GTP, I'm sure you've all seen
Sure.
that.
Yeah.
When you think about how the AI technology, which is just continuing to blossom, is going to integrate with the robotic platforms, it gets more and more exciting. I mean, it's going to be fun to see what we do over the next 10 to 15 years even.
And that is a perfect segue into your special issue that you're going to be guest editing with Luca Milone. You're going to be doing a special issue on artificial intelligence and gastric cancer, specifically.
Wow, nice.
So that's very exciting for us. We're really looking forward to that, and hopefully you can get some authors to contribute to how they use indocyanine dye, maybe hyperspectral imaging in the treatment of gastric cancer, and also real-time endoscopy for the diagnosis in real time of gastric lesions. There's so much there. It's such a rich field that we're really looking forward to that. Have you? I hate to put you on the spot, but have you started contacting any any potential authors yet?
Not quite yet. It's on the list. It's on the short list though. So we're
I
getting
remember
good.
we had to delay this podcast because I believe you were at Sages, right?
I was, there have been a few meetings. I unfortunately wasn't able to attend Sages this year, but I was at SSO, and there was another meeting before that. So.
Okay. Well, I can't thank you enough for doing the podcast and being part of our journal, being one of our editorial board members. It's really, it's great that you're on, and we're looking forward to working together. Vincent, actually, I'm going to let Vivian, I'm going to let you have, if you have any comments, and then we'll let Vincent close us out.
Yeah, well, I just wanted to say thank you so much. I am a huge fan of both you, Andrew, and Vincent, and the journal and the efforts that you're putting into making this journal and bringing all of these great ideas to the rest of the surgeons out there. So thank you so much. It's exciting to be part of all of this, and I appreciate the opportunity to be here. Vincent,
before I let you close things out, I just was reminded. Have you met Gregory Raskin at Memorial Sloan Kettering? Does that ring a bell? It
rings a bell. I don't know him. Yeah.
He is, we went to Yale together, and he works on innovation and technology, vice president of he went to medical school, but we went to Yale together. So it just, while I was talking to you, I was like, I've got to put you guys together, but
on my list already.
Okay, great.
I'll look into it.
Great.
Thanks.
Vincent, take it away.
Thank you. Sure. Thanks, Dr. Strong, for joining our podcast. And for our audience, please do go to mskcc.org, the Memorial Sloan Kettering website, and in the search, do review Vivian Strong, her department, the work she's done. It's astounding. Andrew and I are very excited to work at our journal, aassurgery.net. And we have 24. This is the 24th podcast, so please do review the others. And we'd like to talk some more, and we'll keep you abreast, Dr. Strong, of what we're doing, and hope to have you back for some new topics.
Sounds wonderful.
Great. We made it happen, guys.
We did
Thanks
it.
so much.
Thank you
so much.
Have a great day, everyone.
Bye-bye.
You too. Bye-bye.